Part 2. When expertise became personal. Public health expertise was not always controversial. For decades, it functioned largely in the background, technical, imperfect, and mostly invisible. When it worked, few noticed. When it failed, corrections were usually quiet and procedural. That changed when expertise became personal. As trust in institutions weakened, authority began to migrate away from systems and toward individuals. Complex guidance was no longer evaluated primarily on evidence or process, but on who was delivering it, and how consistently. This shift did not require a coordinated effort. It was a natural response to confusion. When institutions struggle to communicate clearly, people look for human proxies they can assess intuitively, from institutions to individuals. Institutions speak in committees, caveats, and revisions. Individuals speak in faces, voices, and confidence. In an environment already strained by complexity, the latter often feels more accessible, even when the underlying information is less complete. As a result, public health authority increasingly became embodied in specific figures. Scientific disagreement, which is normal and necessary, was reframed as personal inconsistency. Updated guidance, which reflects learning, was recast as unreliability. This personalization made expertise easier to attack, defend, or dismiss. A system can absorb critique. A person cannot without becoming the story. Why personalization works. Personalization simplifies judgment. Instead of evaluating methods, data, and uncertainty, people are encouraged, often unintentionally, to evaluate tone, confidence, and perceived alignment. Once expertise is tied to individuals, disagreement feels like betrayal. Revision feels like deception. Nuance feels like weakness. This dynamic is especially potent in public health, where uncertainty is unavoidable and recommendations evolve as evidence accumulates. The cost of making experts, the message. When individuals become symbols for entire systems, consequences follow. Debate shifts away from institutional capacity, funding, and preparedness, and toward loyalty or opposition to particular figures. Questions about infrastructure and decision-making are replaced by arguments over credibility and character. This does not improve understanding, it narrows it. Over time, public health guidance becomes harder to evaluate on its merits because it is no longer received as guidance, it is received as advocacy. What to watch for. As this series continues, notice when policy disagreements are framed around personalities rather than processes, critiques focus on tone or consistency rather than outcomes, individuals are treated as proxies for complex systems, institutional failures are personalized instead of examined structurally. These are signs that expertise has been detached from the institutions that support or undermine it. Why this matters. Going forward, once expertise becomes personal, it becomes fragile. Removing or discrediting an individual can feel like resolving a systemic problem, even when the underlying structures remain unchanged. This creates an opening for rhetoric to replace capacity and confidence to replace preparation. Understanding this shift helps explain why later public health debates become less about evidence and more about allegiance, and why restoring trust is far more difficult than losing it. That dynamic becomes clearer in the next phase of the series. Next, repetition as policy signal.